SwipeRx.
Hi everyone. Good afternoon. First of all, I would like to thank everybody for spending your weekend afternoon with me today. So it gives me great pleasure to talk about tension headache. And we're going to go a little bit into the treatment and how to recognize what type of headaches there is. Okay. So these are my disclosures. Okay, so headache is very common nowadays. I'm sure you or it's very commonly encountered symptoms in our practice, and also I'm sure it must be in the pharmacy sections as well. So at any one time, according to this research, which is produced quite a while ago in the Kafalangia, which is a world-renowned journal for headache, it shows that at any one time, there's about 46% of people suffering from active headache. So that means about 1 in 2% is actually having headache at any one time. So that's quite a significant amount. Okay, and out of all of these headaches, actually 42% belong to tension type headache. So contrary to the popular beliefs of public, whenever we ask them what type of headache did they have, they tend to say, oh, I have migraine. But in actual fact, when you talk to them, when you further take the history and examine them, it's actually most of the time it turns out to be tension type headache. Only 11% of all headaches belongs to migraine, and 3% of the population actually suffers from chronic daily headache, meaning they have headache on most days of the month. So, according to another study, the global prevalence of headache is about 2.33 billion people worldwide. So actually, to neurologists, it's actually most common disorder that we encounter in our practice. It's the second most common cause of chronic disease and injury because of its prevalence, high prevalence. And of course, when you talk about tension type headache being more common than migraine, the global burden disability is far greater than migraine. In terms of the sex ratio, is more in female, but with a smaller ratio, 1.2 to 1. And the symptoms onset usually started at the age of 30 and above. Between 30 to 39 is more prevalent and slightly decreases with age. Okay, so to further go into the discussion, I will be giving about 3 case scenarios. These are all real patients that we encounter in our clinic. In our center, we have a headache clinic. So most of our patients actually are migraines, because migraines are technically more severe. So tension type headache usually will be seen more in the GP settings, but we do get sometimes chronic tension type headache where they're being referred from the GP for symptom control. Okay, so let's start with the first patient. This is Madam Mila, who is a 39-year-old lady. So she's been complaining of a daily headache worsening over the last 3 months. She had a bit of a history of anxiety and depression, but she's not willing to disclose to us what's her background or whether she's on any treatment for that. She's allergic to NSAIDs, but she described the headache as a pain that starts at the back of the neck and then moves forward to the forehead. And this pain is characterized by sort of a tightening band or pressing in nature. She denies any nausea, no vomiting, she has no blurring of vision, she's not sensitive to light, phonophobia. Photophonia is actually sensitivity to sound. So these are common symptoms that we've encountered in migraine patients. So it's actually one of the criteria that's needed for migraine. So if the patient doesn't have photophobia and phonophobia, so it may be a different type of headache. Okay, and on further examination, when you palpate around the muscle, she has some precranial muscle tenderness. So precranial muscle tenderness is actually also common in tension type headache. So when you press around the precranial area, meaning at the forehead or at the back of the neck, or even of the back of the head, the patient may be feeling a bit tender. Okay, so before we go to the diagnosis, so the answer for this scenario, the first step, what we need to do when we first encounter this kind of patient is we want to exclude secondary headaches. So what are secondary headaches? Secondary headaches are headaches that are caused by usually something sinister, such as space occupations, infections, or bleed or stroke. Why is it important? Because the treatment will be different, and you need urgent treatment rather than the primary headache where you can take your time and then you can start with medication slowly. But for secondary headache, usually they need intervention and they need more investigation as well. So how do we do this? Is by doing a screening, sort of a screening history. So for a patient with headache, usually the consultation can take up to 60 minutes to 90 minutes. So it's actually quite tedious because there's a lot of questions to be asked. Okay. There's a mnemonic called SNOO where we try to screen for the red flags. So the red flags questions are the questions that can lead to possible secondary headaches. Okay? So if after the history and physical examination, we couldn't find anything wrong, the SNOO question is negative, there's nothing that's gives you a warning that this could be something else, then you try to identify what type of primary headache syndrome it is. Okay, so the most common types, of course, is the tension type headache, and you also have migraine. Then you also have the sort of the rarer ones, hemicrania continua, cluster headaches. Okay, and usually they have further separation into episodic and chronic. So what episodic means is the frequency of the headache is less than 15 days per month, whereas chronic is more than 15 days per month. Okay? So if at any one time, even if you have labeled this patient as primary headache syndrome, you should assess for acute medication overuse, which are common. By the time patient presented to us, usually they have been to multiple doctors before. So they would have been taking multiple medications, painkillers. So these painkillers, if they are taking this excessively, it can lead to acute medication overuse headache. Okay, so even if a patient has suspected acute medication overuse headache, you should go back and try to evaluate for secondary headache, meaning you need to do further investigations such as MRI or CT scans to make sure you're not missing out on the secondary cause of headache. Okay, so these are the SNOO questions. So it's quite straightforward lah. As for systemic symptoms, so you during the history taking, you ask whether the patient has history of any fever, has they lost any weight, are they well, or they're constantly fatigued. So if they do, you would think of secondary causes such as infection, cancer, whether it's primarily from the brain ataupun it could be mets from somewhere else, inflammation, which is not uncommon, vasculitis, especially in young patient ladies, okay? And stands for neurologic symptoms or sign. So if you perform, usually we would do a simple physical examination, neurological examination during the consultation, and you assess the power, the tone, and everything, and you ask them to walk, and you check their gait, And if there is anything abnormal, then you should think of something else, then you should order further investigation. The onset of the headache is also very important. Any headaches that started very suddenly, then you should take as a warning sign or symptom. Okay. Thunderclap headache is a term that is used for headache that started very, very suddenly. Why thunderclap? Because it sounds like a thunder and it's very fast. Okay. And if a patient said that he or she has a headache that started very suddenly, for example, if they're just doing their own thing and then suddenly they get this headache that is very severe that they never had before, and it's it just started within a matter of seconds, then we should think of thunderclap headache. So there are several types of several causes for thunderclap headache. Most commonly that we should be worried about is bleed, of course, in the brain. So subarachnoid hemorrhage, where they get bleeding into the arachnoid space, or any type of bleeding intracerebral hemorrhage, bleeding into the brain tissue. And there's also this term called RCBS, reversible cerebral vasoconstriction syndrome. So it's a very old term. It's actually meaning there's a vasospasm in the brain blood vessel, potentially causing stroke. So be very wary if somebody has a headache that started very suddenly and very severe. Okay. Headache usually started a bit earlier, the onset of the headache. So such as tension time headache, the onset usually starts around 30s. Migraine, they started a little bit earlier than tension type headache, around 20s, or even you have the adolescent migraine. So for somebody who is elderly or the age is more than 50 years old, you always need to think of secondary type of headache. Okay. There's this condition called temporal arteritis, where you get inflammation of the artery that is just at the temporal area of the brain, of your scalp. So if there's inflammation there, that can potentially cause blindness. So if it's not caught, then you're missing out the time for the treatment. Okay? And if somebody has headache that has been going on for a while, but has been seen to be progressive, so it's becoming more severe or more frequent. Now, of course, this needs further investigation. Usually, we would also do in the office. We also check for papilledema. Look at the back of the eye and see if there's any swelling of the pupil, the disc of the pupil, because that can signifies increase in intracranial pressure, and that can be a sign of space occlusion or malignancy. Okay, so as I said, both of these headaches are the most common types of primary headache: tension time headache and migraine. So the difficulty is how do we detect one from the other? And is it important to differentiate between the two? Of course, it is important. Number one being because it's the treatment is a little bit different. Okay, migraines are more popular nowadays because there are new treatment options. There are biologics that are coming into the market, such as subcutaneous, galcanezumab, that's been shown to improve the prognosis or treatment of migraine. So some medications that works for migraine will not work for tension type headache, and vice versa. So it is important to educate the public as well that it's not just migraine. Sometimes patient may say, okay, I have migraine, but that's not exactly true, unless they are properly diagnosed and investigated previously. Okay, so tension type headache, usually the pain is tightening and pressing. Patient usually will describe it as a band around the head, and usually it's in the frontal area, also at the back area. Okay, and migraine is sort of a nagging, pulsating, throbbing. The patient can say, I feel like there's like a bomb, waiting to go off in the head because it's always pulsating. Okay, tension type headache is usually bilateral versus migraine. Mostly are unilateral. You have incidences of migraine which are bilateral, but it's quite rare. Mostly is one side. So one side at one time, but it can move. Sometimes it can be on the right side, sometimes it can be on the left side, it doesn't matter. In terms of severity, tension type headache is a little bit better compared to migraine. It's a mild to moderate versus migraine. Usually, if you ask about the pain score of the headache, usually we'll give a score of 1 to 10, 10 being the worst type of pain that they ever had before. So migraine sufferers will usually rate it like, around 7 to 8, something above 5 usually. But tension type headache is usually mild. But there are instances where it can get worse, like, if you have certain triggers, so it goes up and down. For patients with tension type headache, usually they can go on with their daily activities. So they don't have to stop. It's very rarely that patient ask for MC or they have to stop and lie down in the dark room like migraine, because they're still able to do some work because of the intensity or the severity of the headache. It's not that bad. But for migraine sufferers, the more work that they do, the worse the headache will become. So usually that's why migraine sufferers will need to stop whatever they're doing. They need to take a rest and take some painkillers and lie in the dark room because of the phonophobia before they can go on. So usually the migraine sufferers will need to take MC frequently because of the headache. Okay. Tension type headache has no other systemic sign. So usually we call tension type headache featureless headache. There's no other features to the headache. There's no nausea, there's no vomiting, they're not sensitive to light, they're not sensitive to sound. Sometimes patients can describe the headache vaguely. It's not very, it's more generalized, it's not at one side, it's not a specific side. In saying that, tension type headache can go on for quite some time as well. Okay? For migraine, the headache usually will last more than 4 hours. Anything that's less than 4 hours usually is not migraine. Unless they're taking some medication, then we don't count it. If the migraine sufferers are having an onset of headache, it needs to go on for at least 4 hours without painkillers. If they, it needs to last more than that. If it's less than that, then it's something else. Whereas tension type headache, because sometimes it can be milder, so the pain can last from hours, and sometimes it can goes on for a few days even. The patient can, even because it's not interfering with their activity, so the headache can go on for quite some time before they seek treatment. Okay, so as I said before, tension type headache can be broadly divided into the days of the month that they suffer from the headache from. So as a general rule, anything that's less than 15 days is episodic. Anything that is 15 days and above is chronic. In research, sometimes they use the term infrequent and frequent. Infrequent meaning something that's like less than 1 days per month or even less than that. So it's very, very infrequent. Okay, so in headache, there is strict criteria that's being used by the International Classification of Headache Society. So it used to be ICHD 1, 2, and then the latest one being number 3. So for every type of headache, they have criteria. So even for migraine especially, but even for tension headache, they have strict criteria as well. So patients need to fulfill all of these criteria before you label a patient as being tension type headache, technically. Okay, so the number one important thing is the headaches needs to be at least 10 episodes. Okay, so if the patient's only having it for first time, second time, you cannot label the patient as tension type headache yet. So you have to wait. Okay, and as I said before, infrequent and frequent, and then all these features that we've discussed before needs to be present before you label somebody with tension type headache. Okay. Okay, these are the chronic tension type headache. In a nutshell, is any headache that's more than 15 days per month. Okay, that's the only difference. So headache diary is commonly used in our center. We do give either the manual one. So this is an example of headache diary that we use in UPM. Actually, we just print it out on a piece of paper. But if you look into the net nowadays, you can Google. Actually, there's a few apps that is developed mostly, originally developed for migraine, but also can be used for tension type headache. Why is it important? Is we want to ensure we have the correct diagnosis. For example, if you label it as episodic or chronic, we need to make sure it's really more than 15 days per month, for example. Because sometimes, even ourselves, we don't remember how many days of the month that we have headache. Okay. It also helps to differentiate between mild migraine versus tension type headache. Because I'm not sure if you can see clearly on the headache diary, there are also, if you have any associated features such as dizziness or other symptoms such as photophobia, phonophobia, you need to jot it down on top of the severity of the headache attacks. So, for example, if patient has a headache that is quite mild for that day, and then they just label it as 1, meaning mild intensity. And then if they have a bit of dizziness and they have photophobia, phonophobia, then they can put a mark. So when you review it the next time in your clinic, then you can make a decision whether is it really tension type headache or is it actually migraine. It also helps patients and also us to identify the trigger, because sometimes the solution is very simple. There is some certain trigger that make the headache worse, okay? And not every pharmacological intervention is needed in all patients. Sometimes the headache is quite mild and you can just give advice and simple lifestyle modification. Okay, so this is precranial tenderness. So it's quite common in tension type headache. Even though the names, it says tension type headache, it doesn't necessarily mean the patient has tension or stress. It's a bit of misnomer. Sometimes where it's really a combination of multiple factors. Okay, but most patients will have this sort of tension in the muscles. Okay, so they may complain of like a pressure at the back, and then because some patient also complains of pain on whenever they are trying to comb their hair. They may have, if you palpate the neck, they may have tenderness or rigidity at the back of the neck. Okay, even on the scapula. So this is what we call precranial tenderness. So going back to Madam Mila, I'm not sure if you remember her still. So she is actually a chronic tension type headache, because when we look at her headache diary, the headache is more than 15 days per month. So sometimes it takes a few visits before we can properly label what type of headache that the patient has. Okay, sometimes you may not be able to identify the type of headache on the first consultation. Okay, so for her, we try to identify the trigger. We advise her to sleep hygiene, make sure she have enough sleeping time every day, adequate hydration, and also relieving stress and all that. For the acute attacks, we prescribe her Norgesic PBS, which is a combination of acetaminophen and orphanadrine citrate. And because it's chronic and it's interfering with her life, so we also prescribe her amitriptyline 12.5 at night. If I don't know if you can remember, she also has underlying anxiety and depression. So this amitriptyline is also like a sort of 2-in-1 treatment for her. Okay, so these are the types of headache in the ICHD3. If you can look at the list, it's actually quite exhaustive. So primary headache, migraine, tension type headache, and then you'll have the trigeminal autonomic capillalgias. So this includes your cluster headache, it includes your primary hemicrania, continua, all these weird and wonderful types of headache. Okay, secondary headaches are the one that is not caused by or not originating from the head itself. Okay, so these are the things that you need to be worried about, that you need to do further investigation about. Most patients will need MRI brain or CT brain imaging. So if somebody has a suspicion of the type of headache, then always refer the patient to see or advise the patient to seek specialist help. So what we know so far, so this is quite a recent 2021 publication by Ashina. So what we know so far about tension type headache is it's not caused by stress. We all know that. But what's the cause? Well, what they found is actually multimodal cause. It's not one thing. So it's something to do with the genetic disposition. So somebody who has a family history of tension headache, they may have more tendency to develop headache. So that's why sometimes you have a patient who's never had a headache before. If you see your friends who's never had a headache before, and then even nobody in the family have headache. So there is some type of genetic predisposition as well. So secondly is myofascial mechanism. So that's why you have the precranial tenderness. Somebody postulate that it could be something down in the muscle tissue itself due to inflammation or ischemia triggering the headache. Vascular mechanism. If there is somebody postulate also, this is due to the increased blood flow in cerebral arteries. But actually, all of these factors are just postulation. They are not quite sure, but what we know so far is that multiple factors plays a role in tension type headache, which is why one type of treatment may not work. Okay, so maybe we need to incorporate multiple medication, multiple types of treatment to tension type headache. So the triggers for tension type headache actually is the same, the triggers for migraine. So sometimes you cannot base or you cannot differentiate between these two based on the triggers, okay? Because anything can trigger, the same triggers can trigger the headaches. Okay? If the patient is mentally stressed or even physical stress, for example, if they are running a marathon or something, so it can trigger the headache as well. If they are dehydrated, hungry, if they have overexert themselves, if they have a change in the sleeping pattern, especially for those who work shifts, if somebody who has been taking caffeine daily, have been taking, like latte every day, every morning, but suddenly they stop on one day, they didn't get their coffee that in the morning, sometimes that can trigger headache. And even if the patient is taking more coffee than usual, that can also cause headache as well. And for us, females, we know that hormonal fluctuations, the change in our estrogen and progesterone also plays a factor as well. So as I said before, multimodal approach is important in pain management. Of course, the first approach is we try the non-pharmacological treatment first, but of course that doesn't always work. Okay, exercise therapy works because it kind of relieves the stress and the prefrenial spasm. Okay? Acupuncture, psychosocial interventions like cognitive behavior therapy, biofeedback therapy, and relaxation therapy also works. Why? Because approximately about 25% of headache sufferers also have underlying social issues or psychiatric issues such as anxiety and depression. It's actually quite common for them to have both of the pathologies hand in hand. So that's why biofeedback and relaxation therapy also helps in the tension headache as well. Okay, we try to identify what's the trigger. We try to advise them on the best lifestyle practice. Maybe ask them to sleep early, maintain a good sleep hygiene every day. Take your sleep at the same time and ensure you have adequate time of sleep every day. For women, it's usually around 8 to 10 hours. Male, 6 to 8 hours. And there's also an analysis that shows that physical therapy, like physiotherapy, has the best evidence for the non-pharmacological method. Okay? Sometimes all of this needs to be combined in one. So you don't just start the patient on pharmacological therapy. You need to incorporate everything together to help the patient. In terms of pharmacological treatment, it can be divided into acute treatment and also the preventive treatment. So this is an interesting meta-analysis that shows the efficacy of the treatments. Okay, so as you can see, the highest belongs to paracetamol, okay, and also a combination of paracetamol with aspirin and caffeine. There's also single studies that shows efficacies of NSAIDs, such as dipine, naproxen, and then also but these are all lower evidence compared to paracetamol and NSAIDs. Okay, so I've looked into several guidelines on the internet, but there's no local guidelines for tension headache, definitely. But we can go into the European Federation of Neurological Society. Of course, paracetamol is the best choice. It's a level A recommendation. And what's good with paracetamol is that you can combine with other agents as well. Okay, the next one is NSAIDs. Okay, also level A recommendation. Ibuprofen and ketoprofen is shown to be a bit better than naproxen and diclofenac. But of course, you need to be wary of the side effects, gastric, hepatic and kidney side effects. Okay, and also there is increased risk of bleeding in patients taking aspirin and whatnot. Okay, combination treatment is considered as the second line. So usually the combination of paracetamol with something else is quite popular, but this is level B combination. So I would usually try a patient on paracetamol or a simple NSAIDs first. If it doesn't work, then we go into the combination treatment. I'm sure we're all aware about caffeine combination. So how does it help? It increases the pain relief activities effects by promoting gastric absorption. But of course, caffeine has its own side effects, can cause a bit of nervousness, nausea, gastric side effects. Okay? We would try to avoid the combination of simple analgesics with codeine or barbiturate because of the risk of medication of reduced headache. Of course, these are commonly used or commonly prescribed by GPs, but usually we try in our practice we try to avoid them. Okay, and of course we have to mention Norgesic, which is a combination of paracetamol with ofenadrine being a muscle relaxant. So it is indicated for tension headache, occipital headache, that is postulated because of the spasm of the skeletal muscle, spasm of the neck area, the pericranial tenderness. Maybe that's why Norgesic works very well. Okay. Just be aware because it has some anticholinergic activity, so you cannot use in patients with glaucoma or myasthenia gravis. Okay, it works because it works synergistically with paracetamol. It works centrally. It has a little bit of effects to the central nervous system. So that's why we think it works better. Norflex is orphanedrine citrate. Again, 100 on its own, 100 milligram BD. Okay, so in a nutshell, the headache management, number one is avoid opioids. So avoid things like Capox or tramadol, because it doesn't work really well, to be honest. And there's a potential risk of medication overuse headache and the potential misuse of the treatment. Triptans, sumatriptans have no role in tension type headache. It doesn't work as well unless the patient has a migrainous type of headache. Okay, so even though muscle relaxant has some role, but according to study, it hasn't shown consistent superiority in clinical trials. Okay, especially in episodic tension type headache. But a combination of muscle relaxant and paracetamol may give some benefit. We also give prophylaxis, same as migraine, but the type of prophylaxis we use in tension type headache is a bit different. Usually is for more frequent, meaning frequent episodic tension type headache, more than 1 days per month, up to 14, or for chronic headache, more than 15 days. Okay, so usually it's in the form of amitriptyline, antidepressant, mirtazapine, or venlafaxine. Okay, beware of special populations management, especially in adolescent. You can be surprised on how many patients of adolescents that we see these days, tension type headache and migraine, they are becoming more and more frequent. Okay, so you need to do a little bit of adjustment in the medication. PCM is quite safe. Amitriptyline can be used, but I wouldn't usually give the rest for adolescents. Same with elderly. Try to avoid NSAIDs if you can, because there's usually multiple treatments that are on as well. Always closely monitored. And of course, pregnancy relaxation. Paracetamol is the safest choice of all, but everything else you need to be cautious in prescribing. Botox does a role in tension type headache. Not usually. This is a study, a single center study that's conducted, if I'm not mistaken, in Germany, where they try Botox, but we don't usually do it. We usually prescribe Botox for chronic migraine patients. Okay, this is the second patient. He's been complaining of almost daily headache for the last 6 months. He has no other associated symptoms. It's annoying, but he's able to do his daily work. Said the headache improves by taking NSAIDs. Therefore, he's been taking them almost every day. When you try to look for the triggers, he denies everything. He don't think that there is any stresses for him. However, he said he sleeps very well at night, about 8 hours per night, which is adequate. But upon waking up, he does not feel rested. So this patient has chronic tension type headache because of the frequency, more than 15 days per month, headache days. And because he's been taking NSAIDs every day, so there's a possibility of medication overuse headache. So we go into medication overuse headache next. So ICHD-3 all again has a strict criteria. So the headache needs to be more than 15 days per month. in a patient who already have a headache disorder. So either they have tension headache or migraine headache, but the headache becoming more frequent, and then they'll be taking regular painkillers more than 3 months, and then there's always, if you look at the HD3, there's always number C, or the end of it, they always say that the headache is not better counted by another diagnosis. There need to be, put a disclaimer that it's not some secondary headache that's causing the headache. Okay, so what's the treatment? Usually we try to stop everything. We usually go cold turkey. We ask the patient to stop any painkillers. Try to look for an alternative. In most cases, you need to prescribe chronic prevention therapy like amitriptyline and whatnot to reduce the frequency of the headache. So as a general rule, you ask the patient not to take painkillers more than 2 days per week, and then or more than 10 days per month. Okay, so this is my last case. Madam S, 42 years old, who has been having headache at the base of the neck and postural scalp pain for 2 months after her accident. She had an accident, which is where she is a passenger, and she suffered a whiplash injury. So this headache started after the accident. She said it radiates to her shoulder. So on top of the headache, she also has some cervical stiffness. So she cannot turn right or left properly. And then, however, when she well rested, the headache becomes a bit better. She has tried chiropractor, she has tried physical therapy, and she's been taking NSAIDs as well, and paracetamol, but seems to find no relief. She also had an MRI, then we showed some cervical spondylosis, C5, C6, disc bulge with indentation of the vertebral sac. So this headache is a bit different because she has a history of MVA or accident causing also cervical problem as well. So this is one of the secondary headache. You can see on the ICHD3 classification, headache attributed to cranial plus minus cervical vascular disorder. So again, a strict classification or criteria. This is actually a cervicogenic headache. In a nutshell, it's actually a headache that is caused by cervical problem. So as a general rule, the headache needs to start after the onset of the cervical problem. If it started before, then it's not cervicogenic headache. And if there is improvement in the cervical disorder, let's say if the patient has undergone injection of the cervical PID, and then the headache should have relief as well. Okay. So this is cervicogenic headache. So for her, we also prescribe Norgesic 2 tabs DS for acute pain. On top of that, we also injected GON, which is a greater occipital nerve block, and we also refer orthopedic team for intervention. So this is GON injection. Basically, it's a combination of lidocaine with steroid. We injected at the back on the scalp. So it's about 1/3 from the occipital. If you draw a line from occipital protuberance to the mastoid process, 1/3 of this line is the area where you have your greater occipital nerve. So we try to numb the nerve using lidocaine and steroid. And usually the effect, if it goes very well, it can last up to 3 months. Okay, so I think this is my last slide. As a take-home message, sometimes tension type headache, even though it's quite common, sometimes it's very difficult to diagnose, even more so difficult to treat. Okay, we also need to consider medication overuse headache. It's quite common actually, especially in somebody who has been having daily headache. They will usually resort to some painkillers, and they may have been using them excessively. So the management is actually the other way around. So you need to stop the painkillers in order to stop the headache. Okay. In most cases, inpatient type headache or psychogenic headache, you need a multimodal approach. You can't use just one treatment. You need to combine non-pharmacological approach as well. You need to combine sometimes several types of medication. And another point is that in at-risk populations such as children, adolescents, pregnant ladies, elderly, so these are at-risk populations. You need to be cautious with what you are giving the patient. Okay, thank you. I think that's all from my side.
Thank you, Prof. Liana, for the interesting sessions. I think we learned something new about the gone injection. Is it like frequently done in the setting?
In our headache clinic, yes, but I'm not so in GP or other places.
I see. Okay, so we have received some questions in the Q&A chat box. For the first question, we get it from Miss Siti. So for pregnant patients who don't get relief with paracetamol, which medication is safe to be given?
Interesting, of course. Sometimes we ran out of options. But in pregnant ladies, unfortunately, there are no clinical trials are being done on them. We know paracetamol is one of the safer drugs to be given. But other than that, other types of painkillers, there's a risk that comes with, so you need to, if you feel that the patient needs a stronger painkillers, NSAID, or something else, like amitriptyline, even, you need to counsel the patient, and then mention to them there is a risk involved.
Okay, so I think there's one more here. Aside from painkillers, can supplements such as magnesium helps to improve headache?
Based on clinical trial, based on the meta-analysis, that we can always go with, as physician, usually we would like to go with evidence-based medicine. So if you look at meta-analysis and whatnot, usually supplements is not included. So I can't say for sure whether it helps. Personally, I have taken magnesium before because I'm also a migraine sufferer, but I don't find it works, but I'm not sure. It may be a case-to-case basis.
Okay. Oh, I think this one is for migraine type. Can Cafox be taken on regular basis, even for months or even years?
For the indication, of course, Cafox, I have a bit of a thing with Cafox, to be honest with you, because of the risk of medication overuse headache. So for my patient, usually I would say don't take it all because most of the patient that's taking Cafox, they find it very difficult to come off them. Don't get me wrong, Cafox actually works very, very well. So especially for migraine patients, sometimes when we prescribe naproxen and whatnot, they find that it doesn't work as well as Cafox. But Cafox comes with the risk of medication overuse headache and dependence as well. So usually I try to stay away from Cafox. We don't even have Cafox in the hospital. So we will go with paracetamol, NSAIDs, and sometimes communication medication. But even for migraine, we usually stick with NSAIDs.
I see. Okay.
But it's famous among GPs as well. So
interesting to see there is no Cafox in your setting.
no.
Yeah. Okay, so the next question. Norgesic also can help with facial nerve pain.
I haven't tried, and it's actually not indicated for facial nerve pain because I think the pathophysiology is a bit different. Facial nerve pain, such as trigeminal neuralgia, is a sort of a nerve pain. So I would usually stick with gabapentin, amitriptyline, lamotrigine, things like that, rather than Norgesic.
Okay, so I think another one is the same question as the first one. For breastfeeding mother, what drug can be given to treat tension headache? I think it's we have answered this. It's obviously paracetamol. Okay. And there's one question here. A friend of mine says that he cannot take food with MSG or else he will get severe migraine. So he's very careful on his diet.
This is actually very true, but you will find that not all patients have the same problem. So for migraine patient, not everyone has the same trigger. So for somebody, the trigger would be food, caffeine, but for someone else, it could be stress or the weather, hot weather. It's not the same. So somebody who is more who has migraine, that is the trigger is food, MSG, is very common. Even chocolates. Sometimes migraine sufferers they are sensitive to chocolate, so cannot take chocolates. Otherwise, it would trigger the attacks. So that's actually quite true.
I see. Okay. I think we need to just find out what is the trigger and to avoid the trigger, right? Yeah. Okay. When to give pizotifen, flunarizine, or propranolol for a patient with migraine? That's about, he's asking about migraine a lot.
There's a lot of interest in migraine.
Yeah.
So pizotifen, flunarizine, and propranolol are all preventive medications. In terms of efficacy, there is no superiority. So you can choose based on the profile of the patient. For example, if the patient has asthma or bradycardia, so you may propranolol would be your choice. Flunarizine can cause sleepiness and a bit of weight gain. So you may not want to use it on somebody who has a high BMI, things like that. So it's individual choice. You need to personalize your treatment. But these are all valid preventive medications for migraine.
Okay, we have two last questions, very short one. Will long-term use of Norgesic will cause dependency?
I don't advocate long-term use of Norgesic. It is meant to be used for acute therapy, so short-term. If you think the patient needs the long-term Norgesic, it needs to be monitored. So you need to check RP, you need to check LFT, frequent blood monitoring. There may be the risk of dependency. I'm not quite sure because it works centrally, same as myonal, but we tend not to use it long term. I would go for short term and then stop for a while and then use it whenever the headaches becomes worse again.
I agree on that. Because it will cause this medication overuse headache in the end, right?
Actually, yes, you're actually right.
Yeah, might cause as well. Okay. So I think there's too many questions coming in. So one last question is actually quite interesting here. Is there any patient or any conditions like heart problems who cannot use Norgesic? Heart problems who cannot use Norgesic.
In the box, on the box of Norgesic, it says for patient, you need to be cautious. It doesn't say do not use or contraindicated for somebody who has heart problem. So for example, patients with heart failure or arrhythmia. So it just says needs to be cautious, but it doesn't say it's. I think it's for somebody who has a heart problem. Maybe they need to check with their heart doctors first before you prescribe.
Okay, thanks, Prof. Liana. I think that's all for our Q&A. There are a few more, but I don't think we have too many times to answer those. Let's proceed to our poll now. Okay, so for dear participants, we do have our polls questions that you can answer. So let's go with the poll question number 1. Yeah.
Okay. Maybe I read it out. So number 1, when are treatments considered effective in headache management? So it's a single choice answer. You can only pick one. A, treatments are always effective for all types of headache. B, treatments are effective for only tension type headache. C, treatment shows efficacy when headache attacks have features of migraine. And D, treatments are effective for chronic daily headache. So I think I covered this in the talk before.
So we have 10 more seconds to go before we end the pool. Okay.
Okay, so most of you answered correct, 82%, 62 out of 76 answered correctly. So it is treatments only shows efficacy for migrainous headache. For tension headache or cervicogenic headache, it doesn't work as well.
Okay. So let's go with
Okay, so this is the next one. Which of the following are not features of tension type headache? So pick the wrong ones. So A is tightening or pressing. B, not aggravated by activity. C, mostly unilateral. D, lasts hours today. So this is the simple one.
another 10 seconds to go. Okay. Let's look at the results.
Okay. So the answer is obviously C. So all the rest, tightening, pressing, nobody answered that, by the way. Not aggravated by activity. So tension headache, usually the patients can still do their daily activities because the severity is very mild to moderate. So usually they won't need to stop. They still can continue on working and do their daily lives activities, even though they're having headache on the background. So the answer is obviously C. It's usually bilateral. So it's more generalized. So some patients also describe it as like a band. So it's all over. Sometimes when you ask them, they can't even pinpoint where the headache is. They just say it's all over the head. So the answer is C. Mostly unilateral, belongs to migraine.
Okay, let's go to the last full question.
So number 3, what is the potential benefit of combining caffeine with acetaminophen, aspirin, or ibuprofen in the acute treatment of PPH? A, caffeine reduces the side effect of analgesic. B, caffeine enhances the anti-nociceptive effects of analgesics. C, caffeine decreases the absorption of analgesics. D, caffeine has no impact on the efficacy of analgesics.
10 seconds to go. Okay.
Okay, so I'm glad most of you got this right. So caffeine enhances the anti-nociceptive effects of analgesia. How does it do so? Is by increasing the gastrointestinal absorption.
Okay.
Okay.
That's all for Prof. Liana's session. Thank you for the interesting one today. I think the pool questions also ended quite well. They are listening. Yeah. Okay.
It's good.
So yeah. Thanks, Prof. Liana.
Thank you for having me.
Hi, thank you.
Bye.
So let's proceed with our part 2 for today. Okay. Okay. So let's proceed with our second one. It's from me. So I am currently a pharmacist in our pro pharmacy. Also a Painwise community pharmacist where we get this Painwise on yearly basis, a certified Painwise pharmacist. So without further ado, let's proceed with this one. Disclaimer. Okay, in this topic, I think it's quite interesting because most of us are pharmacists here, community pharmacists especially. So we need to understand different types of headache. What are the questions to ask our patients? When to refer? And we'll explain about vicious cycle of spasm and also pain, and the synergism of muscle relaxant and analgesic with focus on tension type headache, TTH, and also occipital headache that we have seen actually quite frequently in pharmacy setting, which also just like how Prof. Liana mentioned, always get confused with migraine. Okay, which I believe everyone's coming into a pharmacy will look for medication for migraine, but in fact, it's actually headache. Okay, so there are two main types of headache, the primary one and the secondary one. The primary one has no known underlying cause. The secondary resulted from another condition that may need further attention. So let's go with secondary headache is very similar to those mentioned by Prof. Liana. So we do some recap here. So it can be symptoms of other underlying pathologies, and some of the symptoms are red flag symptoms that we need to refer immediately. Then examples of the symptoms are hypertensive emergencies. That is why it's actually a very good practice for us to always do BP checking. Always do BP checking for those who come in to look for painkillers, especially headache. So it's a practice in our pro actually to screen BP for all patients coming in looking for analgesic. Then idiopathic intracranial hypertension that we have no idea about, carotid or vertebrobasilar dissection, space occupying lesions that we have never known, but I actually encountered this a few times coming looking for medication for migraine and sakit kepala, but actually when we ask more questions, it's due to untreated tumor. Actually, the patient know that he or she is having tumor, it's already metastasized to stage 4, but refuse to get treatment. So in this setting, we also in pharmacy, as a community pharmacist, I think we play an important role in educating patients on the importance of getting treatment early and getting treatment for their malignancy. And it's another thing is acute hydrocephalus that we never know also. because we can't diagnose at physically and when we see the patients. Dural sinus thrombosis, anything to do with sinus. So there's also one type of headache also called sinus headache. Intracranial hemorrhage, of course, all these are life-threatening diseases, life-threatening conditions. Cerebral vascular accident or stroke, even mild stroke also can be presented with headache that we never know also. Meningitis and encephalitis. So this is very rare. These are very rare, but who knows? Toxin exposures or withdrawal. That is why we need to ask a lot of questions. We need to understand the history and how does it originate. Then acute angle closure glaucoma. Because for patients with glaucoma, it's actually indicated, it's contraindicated to give muscle relaxants, okay? And then medication overuse headache, just like what we have been discussing just now in part 1, okay? So the common triggers of headache in daily settings for our patients is alcohol, particularly red wine, certain foods such as processed meats that contain nitrates, and also mentioned by one of our participants just now, MSG, consuming a lot of nicotine, smoking habit, changes in sleep or lack of sleep. So those who are always on shift work, you will find the patients who are always on shift work, not sleeping regularly, and then getting a very minimal time, very minimal hours of sleep, they will tend to have this kind of problem. Then a very poor posture. This one, poor posture, it can refer to physiotherapists. Physiotherapists will also actually telling us that wrong posture of sitting actually for those who are always in office setting, when they're sitting for 8 hours at a very poor posture, wrong posture, it can cause the muscle to become very stiff and eventually lead to headache. Physical activities such as exercise, too vigorous exercise and they're not doing it right. Skip meals. Skip meals also can cause headache because change in the habit. Coughing, sneezing, blowing the nose, straining or laughing or crying vigorously also can cause headache. So usually when it comes to coughing, sneezing, blowing nose, and also due to sinus, it can also cause sinus headache. And there are 3 types of primary headache that we can see in common settings, okay? So we have this migraine type headache, tension type headache, TTH, and also cluster headache. Let's recap what we do just now. For migraine headache, it can last for 4 to 72 hours. For tension type headache, it can last from 30 minutes to days or even week. For cluster headache, it is quite uncommon, but it is more common in men than women. So cluster headache usually affects the eye. Okay, for migraine, it's moderate to severe. The frequency is very variable, so it can happen at any time, any frequency. Usually, it's accompanied by feeling nauseous and vomiting, phonophobia, fear of sounds, photophobia, very sensitive to light, and the pain will worsen with activity. That is why they need to get rest when there is migraine attack, and it affects 2 to 3 times more women than men, especially when the women are actually on their menstruation period. For tension type headache, is usually affecting the frontal. Here, they will feel that there's a very tight band pressing the head, the forehead. It may last for 30 minutes to 1 week. So that's why when patient is telling you they're having migraine and it doesn't last for more than 4 hours, it can be due to tension type headache. So the intensity is very mild to moderate, pressing and tightening feeling, frequency also variable, and it can be with or without the tenderness over here, okay? But sometimes it may be accompanied by nausea and vomiting, but it's not common. Not common also for phonophobia, not common also for photophobia, and it's not worsened with activity, so they can carry on with their daily activities. Still more common in men than women. But this one is quite special. So for cluster headache, it may last for 15 minutes to 3 hours. Definitely not migraine because it's less than 4 hours. The intensity is very severe. You can feel the pain inside the eye or around the eye area, and it's usually unilateral. Sometimes it can be bilateral, but most of the time it's really unilateral only. One side only of the eye is very painful. It can last up to 8 times daily, can occur up to 8 times daily during the attack. The patient will feel very restless, ptosis, nasal congestion, redness in the eyes, teary eye, and also facial sweating. So it can be something like accompanied with all the sinus symptoms. And this one, it affects 3 times more men than in women. Okay. So the most common that we see will be these two, migraine and tension. So let's move on to tension type headache, or we call TTH. It occurs when the neck and scalp muscles become tense and contract. May occur at any age, most common in adults and older teens. You can see secondary school students complaining about headache. And it's very common. Lifetime prevalence ranging from 30% to 78%. And it's known that everyone in their life must have experienced some form of headache in their life. This is why as high as 78%. And it has very high social economic impact because once we have headache, even though it's not worsened by activity, but it's also one of the reasons for a lot of MC being taken and also affecting the work if the TTH lasts for up to 1 week. Or you can see that it's the chronic type, it will last for more than 15 days per month. When it comes to occipital headache, it is the result from pinched nerves or muscle tightness in the neck area. So behind here, it can be also due to trauma, head or neck injury as a secondary headache, but leads to occipital type. So it's like behind here. These are the occipital lobe of the brain. So it's somewhere that you can feel it's very tight, and sometimes it actually radiates up to the shoulder. Okay. So the symptoms of occipital headache is continuous itching, burning, and can feel that it's actually throbbing, quite similar to migraine, with intermittent shocking or shooting pain that starts at the base of the head and then goes to the scalp or both sides of the head. So it can be bilateral also. And sometimes some of the patients, they have pain behind the eye that mimics a little bit of the cluster headache. And then any movement as light as brushing hair or moving, turning the head may trigger the pain. And you see, it's often described as migraine-like. So similar symptoms to migraine and also cluster headache. So in this type of patient, we also need to find out whether it's occipital or migraine or cluster headache so that we can actually give the correct treatment to our patient. So the questions to ask when someone come in to look for ubat tahan sakit. So always go with what we say, 3WH and 3AMM. 3WH, we can ask for who is for who, what is the condition. They will tell you it's for headache or toothache. And then why, how does it happen? So usually you go with this one, age of onset, you can go with time, character, features, response, and intervals. Age of onset, if the age of onset is more than 50 years old, it is one of the red flags that we need to take note of. Frequency and pattern. Frequency and pattern, we need to ask properly so that we can write proper referral if we need to refer. So we can also find out whether this is episodic TTH or chronic TTH if we manage to identify it as TTH. The duration, how long does it last? 30 minutes, 15 minutes, more than 4 hours, 30 minutes to 3 hours, or can last up to 1 week or even months. So we can see how long does the duration last. Then we can identify it. The character is characterized by the location of the headache. When it's like they're telling you it's tightening around here. So here we can know that it could be TTH. If it's here, it can be occipital. If it's in the eye, it can be cluster. If it's like one side unilateral, it can be migraine with throbbing. So the nature and the intensity can be mild, moderate, and severe. When it is TTH, it's usually mild to moderate. When it is migraine, it's usually moderate to severe. When it's cluster or occipital, it can be very severe. So the nature of the pain also we can see is whether it's throbbing, pressing, or sharp pain. Okay, then you can identify what type of headache the patient is actually suffering from. For associated features, we have another like symptoms. Symptoms such as nausea, vomiting, sensitivity to light, sensitivity to sound, whether any movement or any activity will trigger the activity further, or any stress, anything done, whether when they are sleeping, they can't really sleep, how long they can sleep. Okay, the causes can be the triggers. You can find out what are the triggers, because sometimes some of the patient they do really know what causes the headache, but it's just that the cause is sometimes unavoidable. So I believe that most of the time the patients will come in looking for analgesic for headache and also for migraine. They will tell you that stress lah. So it's like it may be different approach when we go for multimodal management. So different approach may be recommended also lah, like physiotherapy or CBT, or even some of them, they may require psychological therapy. Okay, so look at family history. Since just now, as mentioned by Prof. Liana, it can be due to genetic. Okay, so what are the response towards the condition? What is the action and the medication taken by the patient? Also, we need to ask. So when you suffer from headache, what do you do? What are the usual medication that you use and can relieve the pain? And from the medications that they can tell you, right, you can also find out what is the type of headache actually. If they are telling you that Carefox is not helping me, so you know that it can be not something due to migraine. When they are telling you that I have actually taken triptans before, but it's not helping at all. So it can be something that you can educate them that is most probably not migraine and you need to get further assessment. And if they can be simply relieved by paracetamol, then it's just go with paracetamol. No need to up titrate your analgesic so high and like promoting abuse in the future. Then intervals of the condition, headache-free periods can be, for migraine, the free period can be very long actually, but when it attacks, the severity is very, very bad. So I can take a look at it so that we can actually find out what is the real problem here. So these are the red flags for headache. Revising what Prof. Liana has shared just now, the SNOOP, S-N-O-O-P here, systemic signs and disorders, check for any fever, infections, inflammations, neurological symptoms such as feeling delirious, easy at fall risk, and then losing balance. Okay, onset suddenly or recently. The onset can be something that is patient is actually having the worst headache or worst migraine that he or she ever experienced. We may have experienced very a large amount of migraine or tension type headache episodes in our lifetime, but if that episode is something that is unusual, abnormal, and really, really painful, and described as the worst ever, this is a red flag to refer. Onset after the age of 50 years can indicate is something wrong with the neurological pathway or even something to do with cardiovascular problem. And then prior headache history that is very different or very progressive, that he or she has never experienced something like this before. It's a totally different type of headache that he or she is experiencing. Okay, so when any of these red flags are captured, please refer immediately. Because as we have mentioned just now, the red flags can be due to secondary causes and can be life-threatening. When you have at least one very urgent red flag or 2 to 3 red flag symptoms presented together, and whenever you are in doubt or unsure what to do, please refer to the nearest facility. And here, whenever we describe pain, is a very universal or very subjective type of description. Then the International Association for the Study of Pain define pain as unpleasant sensory and emotional experience associated to a real or potential tissue damage. So it's something that is emotional and very unpleasant. So that is why we do have this pain score from 1 to 10 to ask our patients to rate their pain score to know how is the pain affecting their daily life. And according to Malaysia CPG, pain is the 5th vital sign that we should look for whenever someone is seeking for medical attention. Okay, it should be as automatic as taking BP, RR, PR, and temperature. That's why one of the simplest thing that we can do in pharmacy setting is check their BP. Okay, I have seen actually few patients who come in for headache medication and having BP of actually at the time of the attack is actually BP is at around stage 2, and some even shoot up to 200. So yeah, so we refer the patient to the doctor immediately lah. And pain elicits a neuroendocrine stress response, increasing the BP, the heart rate, the pulse, and the respiratory rate. That's why you see our patients who are in pain, they actually sweat a lot and they're very anxious. Try to calm them down. You can take a second BP reading and still refer if you still get a very high BP reading. Okay, let's talk about this pain, spasm, pain cycle. Spasm, pain, spasm cycle, it can be mentioned this way, or we call this as the muscle spasm. The acute pain can lead to reflex vasoconstriction, low mobility, and impaired muscle metabolism. Hence, it is causing a buildup of waste products inside the muscle and cause the acidity. And it has caused this muscle spasm when it is too much. Okay, so if we never relieve the spasm and let it be there, the pain will not be gone. So as long as the muscle is still, the muscle spasm is always there, that's why you can hear that ketat very tight, you can feel that it's not relaxed. That is why the pain is always not relieved when it is too tight. And the pain will worsen the condition when there is no breaking off of the cycle. So if there is nothing to break this pain spasm, pain cycle, your patient will remain to be in pain. That is why some of them are actually taking the painkiller for quite long, or some of them think that they can handle the pain and they refuse to take any painkiller. So roles of analgesics in the management and treatment of pain, they are very commonly used one. They include several classes: acetaminophen or paracetamol, non-steroidal anti-inflammatory drugs or what we call NSAIDs, antidepressants, anti-epileptics, local anesthetics, and also opiates. So we can also have these topical NSAIDs to be applied, to be used. These are drugs which are used to relieve pain without altering sensory awareness and consciousness or blocking the conduction of nerve impulses. So without altering the nerve impulses, okay? But for analgesics, some of the analgesics, especially NSAIDs, we may see there are side effects like gastric problems, which we resort to paracetamol or other than NSAIDs. We also have to check the 3-AMM, meaning allergy. So when there's a lot of when there is allergy to NSAIDs, that can cause it's actually quite common that we never know. Usually when they are having allergy to NSAIDs, when they come in to look for painkiller, we may not know that they are allergic to NSAIDs. So you can add on in your daily practice, ask one more question, that is, do you have any medication allergy? Okay, because I believe that getting painkillers in pharmacy setting is actually very common. And let's go with role of muscle relaxants. Our muscle relaxants can be divided into two major classes. We have antispastic that acts directly on the spinal cord or the skeletal muscles. It's a direct acting with the aim of improving muscle tightness and also spasm. Okay, this one is acting directly on the spinal cord. Example of antispastic are like baclofen, okay, Lioresal. And then antispasmodics helps to reduce a muscle spasm via the CNS, central nervous system. They work by inhibiting the transmission of neurons in the brain. That is why they are not sending pain signals to the brain. And one of the examples of antispasmodics available in the market is orphanadrine, which I think is very common in pharmacy settings too. So it can help to stop the vicious cycle of pain with powerful synergy with paracetamol. When there is muscle injury, okay, there will be pain here. If we never interrupt this cycle, if we never add on orphanadrine to interrupt this cycle, there will be increased pain, increased muscle spasm, and unrestored muscle function. So it will be keep on going until we chip in. So what do? We chip in with orphanadrine citrate plus paracetamol. And we will see the synergism in the next slide, yeah? So orphanadrine works centrally. It acts within the higher levels of central nervous system by inhibiting the neurons, interferes with reflex pathways for pain and skeletal muscle contraction. And then pain caused by muscle spasms, they respond very well to orphanadrine. Study has shown that. If you want to try, you can try. One, exhibit analgesic effects independent of its muscle relaxing effects. So it exhibits analgesic effects, yeah, of orphanadrine. When it's synergism working together, so we have orphanadrine and paracetamol working together to relieve pain and to stop the pain spasm pain cycle. For this one, orphanadrine, when recap, it works centrally, acts at the nervous system, interferes with reflex pathway, and also skeletal muscle condition. Pain caused by spasm responds very well, exhibit the analgesic effect, and at the same time, adding paracetamol to induce the analgesic effect. And as we all know, paracetamol has always been the first line of choice as analgesic for the management of chronic pain due to its safety and efficacy. It can be used in pregnant and breastfeeding mothers, okay, and also safe for children. Relief helps to release mild to moderate pain, and it works peripherally and also centrally at the same time. In studies, around 90% of patients, they actually rated Norgesic as effective in relieving pain and also spasm. Okay, what are the criteria used for these studies? It's a uniformly good. A patient will return and volunteer that pain had been relieved. or where the patient did not return after being prescribed Norgesic. So if you see your patients not coming back for Norgesic or any painkiller, it's actually a good sign that the medication that you have suggested is working well for them. Okay. Fair result is the relief was not complete, had we continued for 10 days. And this one, we need to be very careful also for our secondary headache medication overuse cost. Okay, we need to identify these patients. If they keep coming back for the same painkiller or the same treatment and keep telling you that the pain is not relieved, I think we need to probe further and may need to do referral. If there's no relief of pain, other forms of treatment had to be initiated. It can be due to we are giving the wrong treatment. Okay. And Norgesic has shown that it helps to obtain better pain management within 5 days itself. And usually if I am the one that actually suggesting Norgesic to patient, we can also suggest that need to monitor in 2 to 3 days. And some patients even telling me that it is relief in 2 days. That's why when we dispense 12 tablets of Norgesic, it's for 2 days usage. So cure in less than 5 days, that is within 2 days. Good one, improve within 2 days and cure in 5 days. Improve one, they'll get improvement within 5 days. When there's no benefit, is within 5 days. So we do the study for within 5 days. But most of the time, 2 days is enough. Meaning you are actually suggesting the correct one. And for this, there is no discontinuation report found due to side effects of Norgesic. So we always advise patients who are taking Norgesic not to operate machinery because it may cause drowsiness. But for patients who are already in pain and need muscle relaxant, they actually like it when they suffer a bit of that side effect because they want to get rest. So when you have this pain or spasm and also spasm, you want your muscle to be relaxed and get adequate rest. So they feel that it's very good for them to have the muscle relaxation, and then they actually end it with sleep and plenty of rest. So we have this Norgesic, indicator for tension headache, occipital headache, associated with spasm of skeletal muscles in the region of the head and neck, and also for acute and traumatic conditions of limbs and trunks. 2 tablets 3 times daily is the maximum dosage. I have this one question being asked, so I'm answering the question. Okay. Available in a pack of 600 and also 12s. Okay, this is the one that we need to be aware of. Ofenadrine shows an anticholinergic activity, hence it should not be used in patients with glaucoma, prostatic hypertrophy, or obstruction at bladder neck, and also myasthenia gravis. Okay. So these are some simple exercises that we can do together to relieve the muscle spasm, especially the tension type here, and also the occipital type headache. So what is cervical rehabilitation? It helps to relieve the muscles around the neck region and also up to the shoulder region. So we can do like this. Can follow me? And then pull it until you feel there is some stretch around the main muscle here. Can hold it for 30 seconds and repeat all these steps for 3 cycles. Okay, hold for 30 seconds and repeat for 3 cycles. The next one is SCM stretch. SCM stretch is when the muscle here, around here, you do this, you can feel it here, and look up, looking up. You can feel there's some stretch around here. Also hold it for 30 seconds and can repeat for 3 times. You can do this on your seat and at the office desk. Okay, whenever you feel there's tense, just do the exercise. One more, we go with levator scapular stretch. Can go with this one to stretch the muscle behind here. Okay, look at the side and pull it. And you can feel the stretch is somewhere over here. Same, 30 hold for 30 seconds and repeat for 3 sets. Neck extension, pull here, put your hand here, and then make sure you do this. And you can feel the back of your muscles are actually stretching and relieving the pain here. When you feel the pain, you stop at the pain. Don't do it, don't overdo it, okay? And one more exercise for this one, but looking at the side. The last one will be chin tuck. Put your finger here and tucking in the chin. Okay, put the chin in. These are some of the simple exercises shared by our pro physio to relieve muscle spasm over here and to relieve occipital headache and also whatever headache that is associated with here, tightness at the shoulder and also at the back. So there are some take-home messages that we need to remember. Okay, the information and other material contained in the slide, including Prof. Liana's slide, there are information and also as professional courtesy. It's not intended to be substitute for professional medical advice, diagnosis, or treatment, and it's only for educational purpose. The views and opinions expressed are not necessarily reflecting the official policy position of iNova Pharmaceuticals. So from us, thank you. Let's go with our Q&A. Let's see, I think there's a lot of questions being asked here. Oh, may I know how to become Painwise pharmacist? Do I have to attend specific seminar or course? Painwise pharmacist is actually a program by the Australian Society. It is a collaboration with our pro pharmacy that is actually organized on yearly basis, annual basis, that you have to attend the course. And usually when there is Painwise, they will invite physiotherapists. It actually is multimodal approach, physiotherapists, NND, nutritionist and dietitian, pharmacists, and also consultant. So yeah, it's a yearly one. You may, I think we may send email or you may email us at or you may email the customer service of our pro also to check how to attend a specific seminar or course. Okay. May I know what is the maximum types of Norgesic used to avoid or prevent MOH? The maximum dose of Norgesic is actually 2 tablets, 3 times daily. Okay. TDS or PRN. Hope that answer your question. I still have a few more to go. What are your considerations in recommending fixed dose combination therapies to the patients? So for fixed dose combinations is actually very simple and also easy because we can ensure our patients' compliance. If you ask patient to take separate dose, they will only tell you that they want paracetamol and they only want to take paracetamol and may need to add on another NSAIDs. But they will tell you, when can I take paracetamol? When can I take NSAID? They'll ask you that way, and you have to spend time to answer them. So when you do fixed dose combinations, It's easy, 2 tablets 3 times daily. And they will not need to tell you that I'm actually taking paracetamol and ofenadine together. They tell you the name directly, Norgesic. So this one can also prevent medication error. Okay. What are the potential risks and side effects of FDCs? Potential risks and side effects of FDCs here, because they have this anticholinergic activity. And also we also always counsel our patients who are on these ofenadine containing medications not to operate machineries because it may cause drowsiness. So make sure you understand your patient and also let them rest well. What are some specific examples of FDCs that are currently on the market? Then there are a few brands available, but the one that I will always confident and comfortable to dispense is combination of paracetamol plus ofenadine because it is safe and it is non-NSAID based, so it does not cause the side effects like what NSAID has caused, like gastric problem or overusage may cause a kidney or liver problem. And it's actually, there is no renal or liver dose adjustment for paracetamol plus ofenadine. Usual pain descriptions provided by patients when they ask for headache treatment options. Usual pain description. Usually they will tell that, I believe most of our pharmacies here, we know that when patients come in for headache and migraine, they will only mention headache and migraine. But we never know that what types of headache and migraine that they are actually experiencing. So I believe from after today's session, most of us are able to identify the difference between migraine and headache because as what Prof. Liana's mentioned, if you are giving the wrong treatment, and if you are, example, if you are giving triptans for those with TTH, it will not work because you identify it wrongly. So we need to identify the correct one and give the correct treatment. So try to do whatever that we have done just now. Ask for the history, the time of onset, and then the age, location, and also the nature of the pain. Then you will know better whether it's tension type or migraine. Do you have specific supplement recommendations for headache? Specific supplement recommendation for headache. In my practice, I actually go with magnesium supplement. Okay, because magnesium supplement and the testimony that we get from our patients or our customers is quite positive actually. So they do help in relaxing the muscles also. It's very similar to what ofenadine has been doing also, but I think if you want to get acute relief, definitely is ofenadine. For supplementation, we know that if you want to take supplement, it's not for instant relief. So if your headache and migraine lasts for that 4 hours, 30 minutes, 4 hours to up to 1 week, if you want to get instant relief, you must get immediate treatment. And ofenadine combination with paracetamol do help quite fast. If you are going for supplementation, they will need to do it as maintenance. So magnesium supplement is, but you have different types of magnesium in the market. So you need to look at the different sort base. I believe that as community pharmacists, we have done few research and doing these EBM studies. The highest absorption rate, I think, in the market is magnesium bisglycinate or magnesium glycinate. So instead of the normal magnesium, maybe we can look into this. So for now, we have been, it's quite common practice for me to actually giving analgesic for headache plus magnesium supplement. Is there any drug interaction of Norgesic with other herbs or drugs? Okay, for herbs wise, as we know that if we are doing pharmaceutical approach plus the natural product or herbs, we try to get around at least 2 to 4 hours before you administer, you're taking the medication analgesic, and get at least 4 hours before patient wanted to take any herbs or natural product. But you also need to make sure that you know what is the patient taking. Get them to tell you what they are taking. If the herbs is an unregistered product, or you know that there is a potential side effect or potential interaction, just tell your patient not to take the herbs until they stop Norgesic, until they get relief from Norgesic. So for drug-drug interaction wise, I think there is not much. Just try to avoid those who are also sedative. Okay, we don't want to get our patient to be too sedative. Okay. Is Norgesic under poison bee dispensed by doctor prescription? Yes, Norgesic is under poison bee, yeah. Norgesic is under poison bee. So I believe that in this world nowadays, I think a lot of pharmacists actually collaborating and also knowing that we are actually doing e-prescription. So you can also refer your patients to e-consultation online. Okay. Let's see if we have any more questions in the chat box. How do we explain MOA of magnesium to help in migraine and headache? It's actually the usage of supplement is very subjective. Like for Prof. Liana, she mentioned that she tried magnesium supplement, but it doesn't work for her. Some patient, they do is working for them, but when it doesn't help in during the attack, okay, it helps in relieving the frequency, reducing the frequency, but when it's really attack, you really need to get acute treatment. Okay, do I miss out any questions in the chat? Let's double check. Okay, I think that's all. There should be no more Q&A that is unanswered. So we can proceed with our pool now. The last one, then let's go with our pool for the second session. Okay, the first question, why is the combination pill of phenadrine plus paracetamol considered clinically superior to using each of its components alone? The 20 seconds to go. Okay, time's up for pool 1. So it's correct, exhibits pharmacological synergy. So we look at synergism leading to better pain relief. So we are not only relieving the pain, but we're also relieving the muscle spasm. When the spasm is relieved, the pain will also be relieved. Okay. Let's go with the second one. How do antispasmodics, such as orphanadrine, work to reduce muscle spasm? Here, any more coming? 20 seconds ago. Okay, let's end the pool now. Antispasmodics, they reduce muscle spasm by inhibiting the transmission of neurons in the brain. The one that is directly affecting the skeletal muscles are antispastics. Okay? If you promote the transmission of neurons in the brain, you will increase the pain. Okay? So you need to inhibit the transmission of neurons in the brain to reduce muscle spasm. There's a last poll to go. What is the recommended dosage for orphanadine citrate plus paracetamol for PTH? Thirty seconds to go. Our last question of the day. Okay, let's look at the result. So the recommended dosage is 2 tablets 3 times a day. If you are giving 1 tablet 3 times a day, you're actually giving sub-dosing. So your patient may recover slower and not recovering at all. and it takes a longer time to recover if you are only giving one tablet 3 times a day. So just maximize your dose and help your patient to relieve their pain faster and more effectively. Okay, I think that's all for today.
SwipeRx.